Our next speaker is Professor Amal Kumar Choudhury, who is a professor of interventional cardiology at the National Institute of Cardiovascular Diseases in Dhaka. He will speak on what is now the holy grail of bifurcation stenting, that is provisional stenting, a case-based discussion.
Respected chairpersons, dear audience, very good evening to everybody. My topic is provisional stenting for left-band PCI case-based discussion. Actually include the left-band and non-left-band provisional stenting also include, but I will give more emphasis to the left-band provisional stenting. Before starting my lecture, I like to remember the birth centenary of the founder of nation, Bangabandhu Sheikh Mujibur Rahman. I have no conflict of interest. Content of my presentation, introduction and principle of left-band bifurcation lesson and what guidelines, trials and algorithms says some case scenario and technique of left-band bifurcation PCI and take-home message. What is the principle? Principle of left-band PCI is stay simple, be humble and seek help if needed, mind set up to take some risks, be clear-headed and a dreamer and no alternative of experience and perseverance. Left-band, among the coronary artery disease, it is about 7% of all coronary artery disease. Syntax score is published. This is the mile clock of left-band PCI. The syntax score is published in 2007, and left-band start in 2009 as class 2B with when IBAS was invented. Bifurcation lesion, left-band bifurcation lesion is 75%. This is a very simple algorithm for both left-band and non-left-band bifurcation lesion. No significant sidebranch involvement. No significant, it is provisional stenting. Definitely it is provisional stenting. There is no, if there is no significant loss, chance of side branch, it is goes straight for provisional stenting. And side branch is not suitable for stenting, also provisional stenting. That means straightforward left band to any LAD or left band to LCX. And if the side branch is suitable for stenting and the lesion of the LCX or side branch is less than 3.5, again provisional stenting is the choice. If it is the lesion involved more than 5 millimeter, then it is it. There is another algorithm which is also simple only for left band, considering the LCX ostium, whether it is angle and whether there is atheroma in the LCX ostium. And depend upon that the provisional stenting or two-stent strategies are adopted. What are the factors we consider before provisional stenting? Bifurcation angle, difference in vessel size, because there is a chance of mismatch, single versus double stent, which double stent technique, and maximal stent diameter, and need for IVAS. What are the technique we can adopt for the provisional stenting? Stent crossover, kissing stenting, stent technique, and stitch technique. And there is the stenting technique after single stent stenting, we can adopt the T stenting, TAF, culotte, and mini crush. We can adopt this stenting after provisional stenting if needed, if jeopardize the side branch. My first case is the STEMI, troponin raise high. There is severe left band stenosis involving the shaft, ostium and carina. And this is the true bifurcation lesion, that means Medina class 111. But the LCX ostium is minor involvement. So what is the treatment strategy? CABG or PCI? Both are, I think we go to take the decision, the syntax score. For this patient, the syntax score was 20. So this is class 1 recommendation and level of evidence B for both CABG and PCI, but patient declined to CABG. So decision for PCI. What are the type of left band stenting? Main branch stenting, if it is confined to the carina, up to carina, single stent stenting. Provisional side branch stenting, usually single stent is usually adopted, single stent, but if required, upfront two-stent strategy can be adopted if needed, and elective two-stent strategy. These are the three forms of left band stenting. So single stent or two stent, all of we know the single stent, if LCX is ostium, is small disease and it is small, and two stent is LCX is large caliber and dominant. So in my first case, crossover stenting left band to LAD was done, and this is the pre-dilatation, and this is the stent placement, and this is the inflation of the stent, and this is the pot, and after spot, there is the significant stenosis of the LCX system. What I do? So recross the wire and kissing balloon dilatation take decision. So kissing balloon was done, and then this is the final result after kissing balloon inflation. So first kissing balloon, so in single stent strategy it is not always mandatory, but in complex PCI it is mandatory to do. So in summary, provisional stent technique is simplest: wire, then stent the main branch and rewire the balloon, and if needed, if it is more than 70% stenosis side branch, the kissing balloon is needed. So this is a very easier case, but after due to time, this is the result after the single stent strategy. We do lot of case. Even then I was guided. We did a lot of case. This is the final result of I was guided PCI, and this is the before and after. And this is also we can do the LCX provisional stenting left ventricle LCX. And this is also another case, severe left ventricle stenting. This stenting was done as left ventricle LAD. So my documented outcome of left ventricle PCI is getting better in last 20 years, and it is comparable to with CABG. Provisional sidewise stenting is the gold standard for bifurcation stenting and better than double stent and mostly practice. Post-dilatation and final kissing balloon inflation are required for optimize the left bifurcation PCI. Coronary imaging, particularly high definition IVAS, OCT, and even sometimes FFR are needed to optimize the long-term clinical result. And it is though the coronary imaging in left PCI is a 2A indication. My cath lab team, and this is my platform, BCIC, and thank you, Victoria of Liberation War in Bangladesh. Thank you.